So good morning all. Thank you all for being here. So this is an extremely proud moment for the Department of Pathology. So our hard work for the past more than 6 months have come to bear fruit. We have standardized MRD in our hospital. So this is a talk on measurable disease, residual disease by flow cytometry in B-ALL. So this is how the talk is going to go. It is going to be taken in 6 parts. First would be the brief introduction, where I will be telling what an MRD is, what is the significance of an MRD. Then we'll move on to the technical aspect of MRD testing. What are the prerequisites for reliable MRD testing? Then briefly on to the analysis, that why BM analysis of MRD is more challenging compared to a diagnostic marrow. Then the main part, which is more important for the clinical side, what are the quality parameters that you should look in your MRD report to see how reliable your MRD reports are. Then coming on to MRD report interpretation. How do I interpret my MRD? So if a MRD report is told as negative, is there any possibility that it could turn out to be positive? So how should I interpret my MRD report, and what are the pitfalls that can come with that report? Okay, so what is a minimal residual disease? It is the presence of leukemic cells below the threshold of detection by a conventional morphological method, by a microscopy, or a standard immunophenotyping like immunohistochemistry. So MRD is a very strong prognostic indicator of B-ALL. So we say a marrow is in complete remission when there is less than 5% blast in a marrow. But it's seen that despite achieving complete remission, there is a report of relapse rate of 40 to 50% in B-ALL. And of these patients who have achieved complete remission, when we do MRD testing, we see that 30 to 40% of them are positive for MRD. So this shows that MRD has a very high prognostic value in assessing the relapse risk in ALL. So also patients who proceed to transplant with MRD positive cases have a higher relapse rate than the patients who are MRD negative. So therapies are aimed at eliminating MRD prior to allogenic stem cell transplant whenever possible. So we always say that B-ALL, the MRD cutoff is 0.01%. So why is that we have put the cutoff as 0.01? This is because the end of induction, it has been seen that when the MRD level is less than 0.01%, it has a favorable outcome. So does that mean that an MRD of 0.005 is a negative MRD? No, still the disease is there, residual disease is there. But as of now, according to guidelines, we are taking the cutoff as 0.01. There are studies which have shown that even lower level of residual disease, less than 0.01, are associated with relatively poor relapse-free survival in childhood ALL. So what are the timings of MRD assessment? We do MRD assessment upon the completion of initial induction, end of consultation. Then the additional time points are guided by the regimens used and the risk factors. Serial monitoring frequency may be increased in patients with molecular relapse or persistent low-level disease burden. So this was a brief introduction. Now, technical aspect, I won't be taking much in because that is not the crowd for taking the technical aspect. But what you need to know is that what are the prerequisites for a nice MRD? So our aim of MRD is reliable identification of abnormal cells and precisely quantify the residual disease. So this is the most important part where the clinicians are involved. The sample preparation. We need a bone marrow is better suitable than a peripheral blood because it's seen that the peripheral blood has 1 to 3 lower blast cells than the marrow. Okay, in case of MRD, the first 0.5 ml is very important. And to avoid hemodilution, we should be aspirating less than 2 ml. Now, what is the importance of hemodiluted and not hemodiluted samples? I'll be covering in the future coming slides. Sample can be collected in EDTA or heparin. So this is our flow cytometry machine. It's a 10 color Navios machine. This is the new working station that we have purchased. We need a high-end working station with graphic card, SSD. We can support the millions of cells that we acquire. So we can't do it in a normal PC. So why MRD analysis is more challenging than diagnostic flow? Why is that we have most of the hospital doing diagnostic flow cytometry, but very few doing the MRD analysis? So in a diagnostic manner, how do we analyze a blast? First, we try to identify the blast. Then we see whether these blasts are abnormal. Then we assign lineage to these blasts. So blasts are identified based on, if you see in this plot, when they're lying in the blast gate. That is a low side scatter and weak 45 expression. And when that is a marker of immaturity. And when they express markers of immaturity like 34, 10, TDT, we know that these are blasts. But then these blasts can be the normal blasts, which is the hematogons, or they can be abnormal. So next we want to see whether these blasts are abnormal. So one thing is the sheer number. In most of the diagnostic manner, we get 80, 90% of blast. The sheer number itself says that this is abnormal. Very few in rare cases, we like dengue, post-dengue, we have seen 40 to 50% of hematogon. But majority of the cases, the number itself says that this is abnormal. Secondly, we see whether these blasts are showing the normal maturation pattern or not. So the maturation patterns I will be telling in coming slides, which will be more clear. So if they are not showing the normal mature, so all these normal blasts in the body, which is the hematogons, will have a proper maturation pattern, which will not be shown by these blasts. And when they start expressing any increase or decreased expression, which is not expected, or an aberrant expression, that is a B blast expressing a myeloid lineage marker like a 13, 33, 15, that is aberrant expression, or asynchronous expression, that is a blast is not supposed to express maturity marker like CD20. So when a blast express maturity marker, that is the asynchronous expression or homogeneous expression. So there are various parameters that we see to know whether these blasts are abnormal. But in diagnostic marrow, even if you try to avoid the blast, it'll be blaring at you so prominently that you just can't avoid it. So it's not a big deal for diagnosing a B-ALL in a flow cytometry. And then but why MRD is challenging? So MRD is more challenging because the blast count in MRD is very low. So we are talking about one cell in 10,000 events, or each event, whenever I say event, it is synonymous to cell. So 0.01% of cells are we are trying to analyze. So the count is very low. Hence the identification of blast among the lymphoid precursors, that is hematogons, becomes more challenging. Then normally in a marrow we have some normal populations like plasmacytoid dendritic cells or mesenchymal stem cells, which are in percentage of 1 or 0.5, which are normally not significant in diagnostic marrow. But when it comes to an MRD, where we are trying to find out this 0.1% of blast or 0.01% of blast, all these normal populations which will show expression similar to a abnormal blast starts becoming significant. Okay, that is another challenge. Then more the events that we acquire, more the issues like the debris, non-specific staining, one cell staining, that is NK cell starts aberrantly taking up CD90. So many issues starts coming as the number of events we acquire. Because in a diagnostic marrow, we are acquiring only 1 lakh events. But when it comes to MRD, it is up to 10 lakh, 20 lakh, that's 1 million, 2 million, 4 million events. That is what we are acquiring. So more the events, more the challenge just comes. Then higher the number of channels. So we have flow cytometry machines which are 4 color flow, 6 color flow, 8, and now 13 color flow. So ours is a 10 color flow. So the number of channels increase. So each channel will have each specific wavelength and fluorochrome with each specific wavelength. However, some of the signals from one wavelength will go and fall into the other. So which can be falsely positive. So the more the channels, more the number of colors they're dealing with, more you have these issues of compensation, overlapping of signals, and false positivity. So these are all the why the MRD is more challenging than a diagnostic flow cytometry. So this is our BMRD template that we have set up in MVR. So it is a 10 color template. We will be having markers, that is a traditional markers, which will evaluate the B cell maturation. That is CD45, 13, 34, 19, 20, 10, 38. 10, 34, 38 is the showing the immaturity. 10 and 34 and 10 are supposed to be told as the immaturity markers, and 38, bright 38 is a marker of immaturity. 19, 20, 20 is for B cell lineage. Then leukemia specific aberrant markers in BMRDs are used. These are 123, 3, all those exotic markers which can be seen in other normally occurring cells in the marrow, like a plasmacytodendritic cell, mesenchymal stem cell, but which can be aberrantly expressed in B cell maturation. So this is our panel of MRD. So what is the aim in MRD? Our aim is to differentiate our abnormal blast from two things. One is the hematogons, that is normal occurring precursor B cells, and second is a normal occurring normal cells in a marrow, that is as I was telling, the NK cells, the dendritic cells, and mesenchymal stem cells. So the principle that we use is that normal lymphoid progenitors has a reproducible antigen expression pattern throughout the maturation. There's a particular pattern of maturation, whereas a leukemic blast will show an altered antigen expression due to the underlying mutation. So we have two approach. One is difference from normal approach, and second is LAIP approach. So difference from normal is what is the deviation from a normal maturation pattern we are seeing, and we are trying to analyze the blast. Second is the LAIP. So sometimes the clinician asks, we don't have the diagnostic barrier immunophenotype, so could we send for MRD analysis? So in the deviation from normal, and that is LAIP approach, what we do is that we have a diagnostic marrow which says our blast is 34 positive, 10 bright. Okay, so what I do is that in the MRD, I just see whether there are blasts which are showing the same immunophenotype as a diagnostic marrow. Okay, I'm seeing here, I'm finding a blast which is exactly similar immunophenotype than my diagnostic marrow. So I say that MRD is positive. So that is a very similar approach. But I'll be talking about this approach in detail. What is the advantage and disadvantage? So most of the time what we use is we use a combination of both this approach. We use a difference from normal, and then in addition we compare it to the diagnostic marrow, so that it will be more confidently we will be able to analyze or call an MRD positive. So the B cells show a maturation pattern. That is the hematogons. There are different stages of hematogon. That is early, mid, late, or type 1, 2, and 3 hematogons. Then they become the mature B cells. So early hematogon will express CD3410, okay, and 38 will be bright. The mid hematogon will lose the 34, will express 10, 38, and start expressing CD20. Then the late hematogon will express 20 very bright. So there is a pattern of maturation for these hematogons. So this is a normal pattern of maturation. So we have this cells. If you see, this is the type 1 which is expressing 10. Then the type 2, 10 becomes dimmer. Then the type 3, 20 starts appearing. Then the mature B cells, which is completely negative for 10 and bright for 20. So there is a particular pattern for each combination for hematogons. So that was for deviation from normal, what we need is that we need to have a template. We need, so that was what we were doing for the past 3-4 months. We were asking for staging marrow. Please send a staging marrow for setting up template. So what do we do here? We run normal marrow, staging marrows, or a case neuroblastoma, or a lymphoma, or an AML. Okay, and then we try to see where the hematogons lie in our machine, in our voltage, and with our antibodies. So we need to run at least 10 staging marrow. How this difference from normal approach require extensive knowledge of the antigen expression pattern. So we need to know what all cells express what all antigen at what all intensity, and following treatment, what are the changes that can come. So it is a bit relying only on the difference from normal becomes a little bit more tricky. So this is how we had set our template. So we had run the 10 staging marrows, and this is all of these are the normal population. This is our type 1 hematogon, type 2, type 3, the normal B cells. So this was a 10-34. That is, type 1 will express 34 and 10. Type 2 will lose 10, lose 34, start expressing 10. Then the type 3 and the B cells. So we set this, we run these 10 marrows. We see, we set a gate where our normal hematogons are going to lie. And when we analyze, we will not tamper with this gate. The gates are going to be very fixed. And then we see what are the abnormal cells that are going to lie outside these gates. So, and then this is this has been taken from the paper from Dr. Tenbare. So in addition, once we have set the template, we need another thing is that we need a gating strategy. So how are we going to take out these abnormal B blasts? So our strategy, what we have set is that we will select out the CD19 positive cases. So CD19 are the B cells. B cells unanimously express CD19. So we will purify out the myeloid cells. We will purify out the plasma cells. All the other cells which we are not interested, we'll purify out. And we will take out CD19 cells. And these 19 cells are put in this template of hematogon, where these normal hematogons are lying. And then we'll see if there are any population which is coming outside the template of hematogon. So if you see here, this is my time gate, the time versus forward scatter, which includes all the events. Then I forward scatter. This is the gate where I've separated out my debris. I mean the doublets. So doublets will lie outside these uniform cell patterns of the cell. And then after that, I've taken out my CD38 positive cells. This is my CD38 positive cells. CD38 positive are the mononuclear cells. So mononuclear cells I've taken out by 38 side scatter. All those with the very high side scatter are my myeloid cells. I've excluded them. I've taken out CD38 positive cells. Okay, from this top is a gauge which is being analyzed in this. So CD38 MHC means I've just taken out these CD38 positive cells, and these are the cells which is coming inside this gate of CD38 positivity. And then I'm analyzing this. From these cells, I have just filtered out my CD19 positive cells. So these are the cells which are expressing only CD19. Okay, and from this filter, this is a filter one I have put. So I'm getting, these cells are not coming into my filter one plot. Only the CD19 positive cells are coming into my filter one plot. And from there, I've excluded my plasma cells, which is going to be CD38 brightest. Okay, and then again, this is including now my normal B cells, my hematogons, other cells which are going to express CD19, all these cells. And this filter, I then put it into my template of hematogons. The subsequent, these are the templates of hematogon. So in this template, what I've included is only CD19 positive cells. I've excluded my myeloid, excluded my plasma cells, and other unwanted cells which I don't want to see. Okay, so this is a gating strategy that we have established for BMRD. But this strategy won't work if the clinician have given an anti-CD19 or following a CAR cell therapy. Then we need to do another strategy, because after giving a therapy of CAR cell or anti-CD19, if you're trying to only analyze the CD19 positive cells, naturally the following treatment, the cells would have lost CD19. So we need to use another markers for taking out those B cells. So we need to have a proper history. So what are the treatment that is given to this patient? In case of myeloma, following DARA, we can use the same gating strategy that we use in a normal myeloma cases. So we need to know what is the history, what is the treatment given, and accordingly we should formulate a gating strategy. Okay, so that was the deviation from normal approach. Okay, now LAIP approach, I told, that was we compare it with the diagnostic marrow. We see what is the immunophenotype of diagnostic marrow. We try to find whether those blasts are there in our current MRD sample. So LAIP is anything is defined as a marker which, based on its deviation from a normal B cell precursor. So any normal B cell precursors, that is hematogons, any marker which is showing brighter expression than a hematogon, overexpression or underexpression of a hematogon, or total negative expression. Normal hematogons are 1034 based on what stage it is. So any total negative, anything deviating from a normal precursor B cell is an LAIP. So MRD is considered positive if 2 or more markers reveal an abnormal LAIP in a cluster of at least 50 to 100 cells based on the sensitivity. So the advantage of this is that because I've seen that my blast is expressing bright 10, and when I see an MRD with a bright 10 expression, it increases my confidence that okay, what I'm reporting is right. This is the abnormal blast itself. Okay, but the disadvantage is that diagnostic immunophenotype will not always be available. Secondly, over-reliance of diagnostic immunophenotype can be misleading, as following therapy there can be immunomodulation, which is a well-known phenomenon. So what is an immunomodulation? So if you see here, this was a diagnostic sample where the blast had expressed very bright 10. But following therapy in the MRD sample, the expression of these blasts has come down and they're lying in the hematogon gate. So if I am relying only on my bright 10 expression on the diagnostic marrow, I will most probably miss this blast. So that is called as the immunomodulation. So markers do not maintain their abnormality following therapy. Okay, and this is usually observed post-therapy. So here we need to use, that is why we are using this multiple markers to purify out these blasts. So this was a paper by Tempare, Dr. Tempare, where they have studied the immunomodulation following therapy. So these were our leukemia-associated markers which we are using, 73, 123. If you see that, in the diagnostic sample, almost 90% of the cases express 73. Whereas, following treatment, okay, there was a loss in 7% of the cases, or 8% of the cases. So if you are just looking for a 73 positive blast, I will miss these 8% of cases. And there was a gain of 73 in 39% of cases. So if I'm looking for a gain means overexpression of 73. Okay, so this shows that all these markers can show immunomodulation following therapy. So we need to use a combination of a deviation from normal approach and in addition LAIP approach. Okay, so I had been telling one main challenge was to differentiate it from the normal hematogons. And the second challenge is to differentiate it from the normal occurring population, that is the plasmacytoid dendritic cell, NK cell, mesenchymal stem cells, endothelial cells. So these cells can also express markers which mimic a blast. If you see for this case, plasmacytoid dendritic cell, they're expressing CD19. Okay, this is not, I think, it is, screen is a little bit, yeah. So they are expressing CD19 heterogeneously, 10, 34. So 19, 10, this is 19 means B. 10 and 34 is immaturity marker. 123 is an LAIP. So why not? Why can't I call this as a blast? Okay, so but then I will not call this a blast if I know where this PD, it could be PDC because the 123 is quite bright. And I've set a gate where my PDC, normally occurring PDC, that is plasmacytoid dendritic cell, is going to lie in my template. So it is so all these normal population can show exact same phenotype as your hematogon or an abnormal blast. So you need to have an extensive knowledge of what these low-lying percentage of cells which can mimic our MRD. Okay, so that was the briefly about the analysis. So from this part I just wanted to show you what are the challenges. Why is it so challenging to diagnose an MRD compared to a diagnostic sample where we are not dealing with the hematogon and the normal population, which is going to confuse us with the abnormal blast. Now this is the important part as far as the clinicians are concerned. What are the quality parameters for MRD testing? So one is the sample quality. Degeneration, hemodilution, hypocellular sample is the main cause of a false negative MRD. Okay, I'll be explaining why is it like that. Second is the events acquired. Okay, it is a key component of sensitivity of an MRD. Again, it will be explained in detail. Then you have to see what is the limit of detection, limit of quantification of that particular assay, of that particular sample. Then whether Cyto13 dye is being used, that is another quality parameter. Then whether the lab is undergoing EQUOS and also the expertise of the analyzer. So sample quality. So degeneration of the sample. So when we outsource it, so the sample reaches after 2 days. If they are analyzing after 1 or 2 days, by that time a lot of degeneration would have occurred to the sample, which will affect the MRD percentage. Okay, hemodilution is another factor. So one important advantage of flow cytometry is that we can assess the sample quality. So there are the parameters which will help us to see whether the sample is hemodiluted or not. So normally in a marrow we see some populations which is indigenous to marrow, which is not found in the normal peripheral blood, like the mast cells, okay, the hematogons, the myeloblast, okay, all these are found in the marrow. So when I see these cells in adequate percentage, I know this is a representative of marrow. And when the granulocyte percentage is more than 50%, so which is not normally seen in the marrow, so there are criteria for us to say whether the sample that I've sent is hemodiluted or not. So in a hemodiluted sample, when I give a percentage of 0.002, it need not always be the accurate percentage. Sometimes it means that the percentage can be even higher. Just because the sample is hemodiluted with the peripheral blood, the percentage has spuriously gone down. So whenever you see in such cases, we put a comment, C comment, the sample, the hemodiluted sample, so please take the percentage with caution. Okay, so if you are having that clear strict criteria of 0.01, only after 0.01% more, if the blast is there, I'm going to change my treatment decision, then you have to be very careful if the sample is hemodiluted or not. Okay, then hypocellular sample. The problem with hypocellular sample is that we will not be able to analyze sufficient number of cells. So I told that for diagnostic matter, we need to analyze at least 1 lakh events. Even means the number of cells. Okay, whereas in MRD cases, we analyze cells in millions. That is 2 million, 4 million. Okay, what we are trying to, in our institute, we are trying to aim to analyze is 4 million. But sometimes, even if I've said that I'm going to analyze 4 million, just because the sample is hypocellular, following induction therapy, the marrow may be going into aplasia, with hardly any number of TCs there. Even if I want to acquire 4 million cells, I will not be. So in such cases, the detection sensitivity will not reach up to 0.01%. So if I'm not for MRD analysis, we need to acquire at least 5 lakh events. So I've just acquired 1 lakh events and I'm telling my MRD is negative, there is a chance that it could be positive. Just because my even number is less, I couldn't find out those positive cells. So events to be acquired for reliable MRD, more the events, better. Okay, that I will be showing why. The limit of quantification, that is the, we have for any assay, MRD assay, we try before starting the assay, we see what is the limit of detection in my instrument and limit of quantification in my instrument. So limit of detection means if I run a blank sample, which is not having any abnormal blast, like a normal staging marrow, okay, even then I will have some few events which is going to mimic an MRD, which will come 19, 10, 34 positivity. Okay, so in the blank cell also I'll get some events. So I put a limit of detection. Okay, only above, if I'm getting an event above 14, as of now we have our instrument limit of detection is 14. So anything below 14 comes, I'm not supposed to report that because it can be a false positive event, which I have seen in my blank cases also. Okay, so whereas limit of quantification is where I can precisely, reproducibly tell the number. Okay, I need at least 50 events in our instrument. We need at least 50 events of abnormal B cells. I need to see 50 abnormal B cells to say that, okay, quantify it reliably. But if it is even less than limit of quantification, the MRD is positive. I can report it. But more reliable quantification is at least if I see at least 50 events. Okay, so for B-ALL, the current threshold I told that is the for clinical management is 0.01%. Hence, for reaching this threshold of 0.01, I need to see 50 abnormal cells. I need to get at least a threshold of 0.01. So the events that I have to acquire is at least 5 lakh. 50 by 5 lakh will give me a sensitivity of 0.01. That is why I told that at least 5 lakh events are to be acquired in an MRD case. So if I don't acquire 5 lakh, 1 lakh, and I say my MRD is negative, there's a chance that the MRD can be positive. So you can send the sample once the count has recovered if you have a clinical doubt. Okay, so the higher the number of events leads to increased detection rate of lower MRD. So in our lab, as I told, we are trying to aim to acquire 40 lakhs events, 4 million. So this is a plot which will explain to you why the events are very important. So all this is a 1, 2, 3 analysis of the same case, same sample with same time. I've taken up this. Only difference in this plot is that the first plot, this is a time versus forward scatter. The events acquired is 64 lakhs. That is 6 million events. Okay, these have been acquired in 4 batches. 4 times I've aspirated. Each aspiration around, I think 16 lakhs. Okay, so 64 times I've merged the data and I've taken out 64 lakhs of cells. Okay, if I come into this plot which is down, what's my cursor? Okay, this is the down plot. The same plot. Only thing is that I've put my gate down and included 5 lakh in my analysis. The same test, at the same time, I'm not include the 64 lakhs in my subsequent analysis. I've just put down the gate and analyzing my 5 lakh. Here I've just put down the gate and analyzing my 10 lakh. So if you see here the MRD, when I analyze 64 lakhs or 6 million, there is MRD of events is 19. When it comes to 5 lakh, events become 2. When it comes to 10 lakh, it comes 3. And 3 and 2 I'm not supposed to report because my limit of detection is 14. Okay. Here my limit, it is coming above my limit of detection. I still can report this as MRD positivity. So that is the importance of number of events being acquired in an MRD. So there are multiple tests, multiple groups which have proposed different recommendations for the events being acquired. So it was the COG group, they did a study with a 6 color, 2 tube, where they told that, okay, that is a 5 lakh event to 1 million is what is recommended. So for LOD of 0.01, if my limit of quantification 50 events I need, that is 50 by 5 lakh, 0.01 sensitivity I've reached. Okay, St. Jude say that it's 1 million, and currently Euroflow used 8 color 2 tube method, and they told that 4 million events is what is required for a very nice MRD of sensitivity of 0.001%. So recently, Dr. Tembare had did a study on 10 color flow cytometry, and they showed that they could achieve a sensitivity of 2 cells in 10 raised to 6. That is 10 raised to, normally it's 10 raised to 4. So if it is in 10 raised to 6, it's as sensitive as the next generation sequencing. Okay. So he said that so it's called as next generation flow cytometry, which has reached the same sensitivity as an NGS. So this was the limit of detection, the same thing which I've told beforehand is a limit of detection for our lab is 14. For our lab is 14, at least 10 should be there. And limit of quantification, at least 15 should be there for reproducible MRD assessment. And each sample, each test, the LOD LOQ varies. So in your report, we are supposed to see what is the LOD LOQ of that test. Okay, why does the LOD LOQ of each test varies? Because you calculate our LOD LOQ by the LOD events that is set in my instrument, 10 events, by the number of viable events that I've acquired. So if I am acquiring just 100 cells, my LOD becomes 0.1. If I'm acquiring 1000 cells, my LOD becomes 0.01%. So each test, when you get the report, you have to check the LOD, LOQ. What is the LOD? Has it reached the sensitivity of 0.01%? Okay, whether the sample is hemodiluted. So there are so many parameters. Just seeing a positive or negative MRD does not fully tell you what the report is. And LOD and LOQ in a very good report will be mentioned at the bottom of patient's report. Now I told Cyto 13 die for calculation, MRD calculation. So when we have joined the EQUAS of MRD. So there is a question, are you using Cyto 13 die or not? So it is an optional. Many labs don't use because it's an expensive die. And we need a sophisticated centrifuge machine, which is used in molecular lab, which is a highly costly machine to for the sample preparation of Cyto 13. So there is an option not using Cyto 13 die. But using Cyto 13 die will improve the accuracy of the report. How? Because what we are doing for MRD calculation is that we are using the number of MRD events out of the total viable events. So any dot, what I see in my flow plot is an event, is a cell. Okay. So normally I will include all those dots, but then some of the dots may be the debris, that is a non-nucleated cells, RBCs. Some of them may be non-viable cells. So if I'm including those non-nucleated RBCs, non-viable cells, my number of viable events will be spuriously high and my MRD will come spuriously low. Okay. What the Cyto 13 dye does is that it will stain all the nucleated cells. So it has all those which is positive for Cyto 13 dye are my nucleated cells. And all those which is negative are my debris non-nucleated cells, which I'll be excluding. So this usage of Cyto 13 dye will improve the percentage accuracy of MRD that we are reporting. And EQUAS. So EQUAS, we always need to have any quality assessment either in the laboratory testing or an EQUAS to know that what we are doing is right. Okay, so this was a EQUAS report that was given. We had enrolled in the EQUAS, and our performance has been termed as satisfactory. The satisfactory is the best. So just hearing satisfactory means satisfactory is the best thing that is being reported here. Satisfactory, action critical. Okay, so satisfactory is good. So if you see, the total participants were 36. Okay, and this shows that the number of events acquired. So our events for that particular MRD was the 25 lakh or 2 million. The median events acquired by majority of the lab was around 1 million. Okay, so the more the events, if you remember, better the performance. And our sample has come as within the lab. This is the distribution of MRD positivity reported by all the participants, and we have a very good inquest report. So we are reliable. Please don't doubt us. So MRD report interpretation and pitfall. So this is how our report is going to be. We'll have the flow cytometry number, the specimen, the instrument that we are using, which is the Beckman Coulter 10 color Navios machine, the preparation method, the gating strategies that we have used. Okay, these are the markers which have shown where we have set our template. Then a brief clinical history of what the case was. A diagnostic immunophenotype would be written here. Okay, and the manner of aspiration findings. And this is our MRD report, where we'll be mentioning which are the positive markers that we have seen in this abnormal blast we have seen. Whether it was so I've seen around dash percentage. I mean 0.1% of abnormal blast, which will be showing CD34 positive or 38 dim. So you can see what is the expression pattern of this blast in this table. And then finally the impression, that is, it will reveal dash percentage of abnormal B cell acute lymphoblastic B cells in an acute lymphoblastic leukemia case. And do read the comment also, plus just don't see the percentage and rely on the report. Do read the comments, whether it is a dilute. So these are the optional comments which will be given according to the sample. In view of the dilute nature, the percentage of MRD may not be representative. Or since LOQ of the sample of this particular sample is 0.003, but there is very low TC. So the number of events could not be acquired up to what we are expecting. Okay, so the sensitivity of the assay may be low. Okay, quantification of may be affected by bone marrow aplasia, may be repeated if the count has recovered, if you're still suspecting an MRD positivity. Okay, so please do read the comments. Okay, and below that we will have the limit of detection of our lab and limit of quantification, that is a 14 and 50, and then we'll put it in the percentage. So it will be 10 divided by 14 divided by the number of events that have acquired. So if it is 1 lakh or 1 million, so the percentage will vary. So please do see what was the LOD, LOQ percentage of that particular assay of this MRD report. Okay, and then we will be mentioning what are the dilution parameters, okay, which will help us to assess whether our sample was dilute, and then some disclaimers. Okay, so that was all about flow cytometry MRD, which I wanted to convey. There are, just for completion's sake, there are other used methods for MRD detection, like NGS or real-time PCRs. So FDA approved NGS-based assay. They detect the clonal rearrangement of immunoglobulin and T-cell receptor loci. Even RQ-PCR also detects the leukemic-specific rearrangement of immunoglobulin. So for RQ-PCR, we need to have a diagnostic sample. We can't do it without a diagnostic sample. Then there is RT quantitative PCR, where we look for that, in case of AML, if it is a BCR-ABL positive or PML RARA, we just look for that fusion transcript in the analysis of MRD. So we see each test has each threshold. Morphology up to 5%. Okay, MRD detection based on if it is a 4-color 1 lakh event, it will not reach up to the threshold. If it is a 10-color flow, which is using 4 million, 6 million, it will reach even the sensitivity used by an NGS of 10 raised to minus 6. Okay, which is supposed to be very sensitive machine for MRD detection. So the advantage for flow cytometry. So this is a comparison of these 3 tests. Okay, we need fresh sample for flow cytometry. That is another disadvantage. We need to process it as early as possible. However, it is relatively less expensive, rapid turnaround time, low labor intensive. Okay, so whereas compared to the PCR and deep sequencing, sometimes we need diagnostic sample in PCR. Okay, it's more expensive. The TAT is quite high. So the advantage is that it is easier, less labor intensive, rapid turnaround time, cost effective. Okay, it will help us to see the sample quality, assess the normal hematopoietic cells, whether it is dilute. We can see we can detect new subclones or a lineage switch of in flow cytometry. Okay, even without a diagnostic sample, it's possible to do MRD analysis in flow cytometry. For TLL, it is preferable to have diagnostic sample because analysis of TLL is a bit more tricky. Okay. So the challenges is that one is the sample quality, as I told, the immunophenotypic shift. Okay, and then introduction of immunotherapy, especially that against markers like CD19. This will require modification of the panel. Okay, we need to have different antibodies. As of now, we have not standardized CD19. So if the clinical side, if they're saying that we are starting to use the anti-CD19, we are starting CAR cell, then we will have to procure more antibodies and we'll have to improvise our gating strategy. So to summarize, MRD is the single most powerful prognostic marker. It is widely available, highly sensitive technique. Knowledge of the normal patterns and therapy-related immunomodulation is required. It needs to be well standardized and validated. Okay, 8 to 10 color MRD can reach a sensitivity of around 1 in 10 raised to 6. Okay, and the templates will help to simplify the analysis. Use of Cyto 13 dye can improve the accuracy of MRD percentage. Thank you.